Today's topic is health equity and the social determinants of health. We hope you sign up for our third session on Eventbrite entitled Addressing Structural and Systemic Change to Advance Health Equity, which will take place December 7th from 12 to 1:30 p.m. You can also watch our last session, Racism is a Public Health Crisis, on MECA's Facebook page at Orange County MECA. This session will also be recorded and be live on our Facebook. We have the pleasure of having some very special speakers with us today, including Sarah DeGia, CEO of Change Lab Solutions, Mario Ortega, CEO of Abrazar Incorporated, Dr. John Ruiz, Associate Professor at University of Arizona, Tina Yuen, who also works at Change Lab Solutions. We are excited for today's topic because we have seen how important the social determinants of health have been during this pandemic, and how it's important to acknowledge the unequal starting places we have as a community, and the need to correct that imbalance, as well as to understand the underlying or root causes of inequalities within our society. In discussing health equity, we need to address the differences and obstacles found between population groups that are systemic, avoidable, and fundamentally unjust. To achieve health equity, we must remove these obstacles and clear a pathway so that everyone has a fair chance to reach their full health potential. To me, some ways to address inequities are providing extra supports when needed to create access, ensure cultural and linguistic responsiveness, and ensure services meet the needs of communities. But to achieve real change, we need to look at our policies and practices, working consciously to design, create, support, and sustain fairness in our systems. We all want to achieve health equity so that every person, regardless of who they are, has an equal opportunity to achieve optimal health. Equality is our end goal, but equity is the means to get there. Thank you for joining us today to have these deeper conversations and collectively understand how we can work together to advance health equity. I'm going to pass it on to my co-moderator, Dr. Miguel Gallardo, who is MECA's Research and Evaluation Director and a professor at Pepperdine University, to get us started.
Thanks, Ileana. Also happy to be here today and excited about the conversation. I'm not going to say a whole lot. I want to introduce Dr. Ruiz and let him take over. But I do want to say that the interest in these workshops has been really overwhelming. Had hundreds and hundreds and hundreds of people. I think we had close to 500 register for this one today, and probably get somewhere around half because some people are registering just to listen to the recording later. But I think it really speaks to the interest and the enthusiasm and the need to really address these particular topics. And so I really want to echo what Ileana said. Looking forward to today's presentation and having a good dialogue. So because we're in webinar format, obviously you will not be able to see, we cannot see you, but we can see your chat questions and Q&A and things of that nature. So if you have questions along the way, please put those in the Q&A. If you have comments along the way that you'd like to share about what the presenters are talking about or other questions, please put those in. We'll be monitoring those and getting to as many of those as we can. We won't probably get to all of those, but we will get to as many as we can and have a really, I think, lively and meaningful discussion today. So let me introduce Dr. John Ruiz, a colleague of mine, known for a while, and just really thank you, Dr. Ruiz, for being here. I know you got a lot going on, so always happy to share some space with you as well. As Ileana mentioned, Dr. Ruiz is an associate professor in the Department of Psychology at the University of Arizona. His research program focuses on psychosocial influences on health. He has an NIH-funded research program that examines the relationships between individual-level psychosocial factors, social behaviors, and cardiovascular and cancer diseases, with an emphasis on biobehavioral mechanisms. In addition, he's been recognized as an expert in sociocultural aspects of racial ethnic health disparities, particularly the epidemiological phenomena referred to as the Hispanic health paradox. And he is increasingly recognized for his efforts to advance health equity. His work reflects a broad range of methodologies, from laboratory to community participatory research to population level epidemiology. He's also a part of the American Psychological Association's Presidential Task Force on Health Equity, and was also a member of the inaugural Health Equity Committee. And he's a permanent member of the NIH Behavioral Medicine Interventions and Outcomes Study section, and serves on a number of other NIH boards and at the university as well. He's a director of the Health Psychology Doctoral Training Program, and also the director of DEI in the Department of Psychology. So Dr. Ruiz, pleasure to have you here. I'll turn it over to you. Thank you.
Thank you, Miguel. Thank you for that introduction. Can you hear me okay?
We can. Yeah, we're good.
Wonderful. That list was exhausting. It was missing my favorite role, which was dad. And I got to take my kids trick-or-treating this weekend, which is, I'll work can always wait for those kinds of activities. Let me go ahead and see if I can share my screen here. Go. Are you able to see that?
Yep, we're good. Yep, got it.
Okay, wonderful. Well, thank you so much for inviting me to be here today. It's a real pleasure to be able to participate, particularly with this panel, but with Mecca and the important work that they're doing. And I'm just going to start by saying how optimistic I feel about health equity efforts in 2021. There's obviously a ridiculous amount of work to be done, but certainly that we are now in a climate where offerings such as this are taking place help me to think that we've turned some sort of corner and that we're beginning to pick up momentum in that direction. I know that we're sort of limited on time. I think, do I have 20 minutes? Is that about correct?
That's right, John. Yeah, that's right. Yep.
I'm just anticipating the virtual hook and when that gets pulled.
Yeah, I'll come on. I'll come on with a few minutes left just to give you that sort of timer. Okay.
That's wonderful. Thank you so much.
Right.
So this is what I'm going to talk about today is, to me, when we think about health equity, it's two words, but it refers to such a large goal, a moonshot, if you will, that it can be overwhelming in terms of how to operationalize an effort to address it adequately and appropriately. So this is a talk that stems from my work particularly with APA, the American Psychological Association. So as we go through, please think about how these kinds of ideas might extend to you and your own context. Certainly the fact that we're having this meeting virtually underscores the context in which we live in, that we are being faced by a massive pandemic. And I think for those of us who work in this kind of space, we are acutely aware and could have predicted pretty accurately that the burden of that pandemic is not shared equally. The recent data out of the CDC coming out maybe about 5 weeks ago now, in fact shows that there was a decrease in life expectancy as a result of the pandemic. And of course that hit minoritized groups much harder than it did majority groups. And so we see things like that the change in life expectancy for non-Hispanic Black males was a decrease in life expectancy of 3 years. For Hispanic males, that was 2.4 years, and so on and so forth. These are examples of broader and more systemic and sustained challenges that have faced underrepresented populations in the U.S. In areas of mental and physical health and well-being, including disparities in the incidence of these problematic health states, their progression to more emerging conditions, treatment outcomes, survival, and of course, all-cause longevity. The determinants of these are exactly in line with the theme of this meeting: social determinants, environmental, interpersonal, the systems that we exist within, and access to those systems and their resources, quality of care, research, importantly, our understanding of these populations, not the generalized expectancies based on a different group, but specificity within a group. The ability to engage those populations and make them a part of that system of care, as well as, of course, ecological, structural, social, and biological determinants. The CDC has recently revised their definition of what health equity refers to, and they describe it as health equity is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. Essentially, the argument that the social determinants should not either preclude or dissuade somebody from achieving their optimal health. The health equities are reflected in differences in life, length of life, and in quality of life, in rates of disease, disability, and death, severity of disease, and access to treatment. The ongoing efforts to address health equity, I think, need to be acknowledged. And many people who are probably viewing this right now are an active part of that effort. It is not that we're waiting for some new strategic plan to come about and be the silver bullet that solves this problem, but rather many folks who are probably listening in right now are actively participating in equity efforts. These things range in scale, of course. There are those who see those with less means, lower SES populations, using sliding scale remunerations as a part of a health equity effort. And of course, those things can extend all the way to federal policy, such as Affordable Care Act. But everything in between can be in our daily lives and our daily efforts, part of this ongoing effort to increase the equity and optimal outcomes for all. It's important that psychology and allied sciences not feel pressured to invent a new wheel to address health equity. That health equity and the existing ecosystem in which it's targeted has many wheels already in motion. And what I mean by this is that if we take a look at the biomedical workforce, or if we take a look at the workforce of the US in general, the largest percentage of folks working are in healthcare. Healthcare is a massive undertaking. Most folks here are either directly involved in that or know somebody who is involved in the healthcare effort. Of course, this biomedical workforce is a heterogeneous population made up of a variety of professions. And it's important for us to recognize where is psychology within that larger effort. The APA, for example, represents 75,000 total members, which seems like a lot. If you had them, that's a small town in some places. If 75,000 psychologists show up to your town, that's a noticeable event. But we should also recognize that relative to the biomedical workforce, 75,000 is not a particularly large number. For example, the American Medical Association has approximately 250,000 members. The leading nursing groups have another 130,000 members. And that while the number of psychologists in the US is estimated to be somewhere around 171,000, there's over 1 million MDs and over almost 4 million registered nurses out there. Each of these groups is heavily involved in equity and invested in equity outcomes, just as psychologists are. Each of us, I think, adds a unique piece of the variance that can help achieve that goal. But to achieve that, the pieces have to come together. Now, I'm probably like a lot of folks who felt it was a long pandemic, and I watched probably more movies than I would in a normal year. One of the particularly popular movies in our household was Pitch Perfect. I don't know if anybody else saw this. Actually, I know most of you probably saw this because you can see the view counts on it. And I know that it's just not possible for even for the number of times my family has watched it for us to have seen it that many times. But the lesson here is that of harmony. And that is, one might have an excellent voice, but you have to sing it in the right key. That voice needs to contribute added value to the rest of the group. And it has to be loud enough to be heard above the others, or at least to a volume that contributes to the others. And in many ways, psychology has to think about this as it relates to health equity and the ongoing health equity effort. Are we in the right key? Of course we are. We have to have the right voice. And I think most of us would say that, yes, as we watch news broadcasts and view this, we wonder, where's the psychology in all of the intervention efforts, which, by the way, are all behavioral in nature. Everything from social distancing to mask wearing to vaccinations have a behavioral element. Where's the psychology voice in that? Well, we need to make sure that we're all singing together. We need to make sure that we're singing in the right key. We need to make sure that we harmonize with the ongoing efforts, and we need to pull ourselves together in groups so that together our voices are audible in that broader discussion. So, for example, one of my roles is as a member of the health psychology community. And Society for Health Psychology, Division 38 of APA, represents about 1% of the biomedical workforce between nursing, medicine, psychology, public health, and others. Another role I have is as the current president of the Behavioral Medicine Research Council. And that's a group that has pulled together the four major US-based behavioral medicine societies, Society for Health Psychology, the American Psychosomatic Society, Academy of Behavioral Medicine Research, and Society of Behavioral Medicine. Collectively, that group comes together and makes about 1% total of that workforce. If, though, that group allies with, say, APA, well, then that voice increases to about 16%. As we build coalitions with shared priorities and unique variants added, we can increase the quality of not only the quality of our message and its harmonization with the broader effort, but the volume so that it is heard and it is impactful. In many ways, I think psychology would be well served to become a bit of a more assertive science. That is, to be clear about our shared goals, be clear about the gaps in expertise that we wish to address, and be assertive about the value of our collaborative efforts. A lot of folks here have seen Hamilton. The room where it happens is perhaps the room where we want to be and perhaps should be, but we need to make sure that we advocate collectively to get ourselves into that room. Now, I said earlier that most folks on this call are probably contributing to the health equity effort in some way, but a familiar sort of model that might help us is something of a social ecological model to help us understand a bit more about how those individual daily efforts can contribute to the overall goal of health equity. So for this next section, I'm just going to go ahead and sort of take these one by one, everything from private practice to partnerships to community to broader sort of umbrella structures such as political systems. At the individual level, where the individual clinician, the individual researcher, the individual student, the individual community volunteer and stakeholder might find themselves, there is an enormous amount of possibilities to shape the discussion of health equity. Building coalition targets remains important. Coalition targets are not just at the society level, they can be at the individual level. And if we think about creating networks of coverage within your locale, a series of practice colleagues, each of whom dedicates a portion of their work to a sliding scale to help accommodate. Together, all of those can begin to create a net of coverage in their local area. This is not all that different from the emerging sort of team science frameworks that are emerging within institutions, where groups come together, each contributing a little bit of effort, but together the aggregate of those small efforts creates an impactful experience. In addition, there can be tailored accommodations amongst those networks. Many of the folks who need equity efforts the most are unable to participate in the current sort of 9-to-5 structures. They need weekends, they need time outside of the normal bounds because of their socioeconomic positions, their jobs, and other conditions that preclude other normal traditional engagement times. A coalition of partners, 3, 4, 5 clinicians who alternate, say, Saturday mornings or Sunday afternoons, can begin to provide a network of coverage that collectively can have an impact. Importantly, there should be some degree of effort within individuals and within small community efforts to understand DEI frameworks. How can we be more understanding and inclusive in our efforts? How can we act with sensitivity, flexibility, and awareness, such that when we do our outreach, it's not just good intentions, but it's tailored good intentions that are impactful and meaningful and received by those communities that we intend to help. And importantly, from a research perspective, it's important for researchers to integrate public health implications into our work. It's always great to advance simply for the advance of science, but importantly, at this time, given the scope of effort needed, it's okay to be intentional in having a public health mission, and importantly, striving to make underrepresented groups not just token parts of our efforts, but truly driving and powering to produce main effect results. For anybody who's ever been low SES, it's not a covariate experience, it's a main effect. At the partner institution level, if you're part of an organization, a professional organization, a 501 group, whatever, again, the same basic logic might be helpful to find like groups, to form local coalitions, and collectively begin to look for equitable financial models, ones that do not overly tax your particular group, but rather share that burden across groups for an overall better community experience. The same can go for hours, as well as accommodations. And importantly, we have to think about, from an organizational standpoint, also how to be inclusive. Does your frontline hospital have staff that speaks languages of its community? Are there navigators to help those who are less knowledgeable about systems get through the myriad of challenges that can be experienced, from paperwork to timeframes to interpretation of results? Striving to improve the qualitative experience of the individual consumer is an important pathway to achieving equity. And importantly, we have to think about adopting infusion types of models where it's not the responsibility of a DEI office or DEI officer, but rather everybody's expectation to be accountable and contributing to the equity effort. At the community level, we have to think about how do we harmonize our efforts and optimize them in ways that meet those of the stakeholders themselves. How can we build in mechanisms so that we can hear the voices of the community and let that be an important and guiding part of our efforts? While most work to date has really emphasized a top-down approach, we're increasingly aware of things such as community-based participatory research and other efforts that are more grassroots, where the community tells us what their needs are. And it's important that we have mechanisms to listen and hear that message, and then work with those communities to optimize the efforts for all. Importantly, the research in these areas also needs to be embedded within these processes. So many 501s will have an excellent set of intentions, outreach efforts, and workforce, but may lack scientific skills or expertise to evaluate the degree to which their efforts are producing outcomes and or identifying the specific mechanisms that are achieving the bulk of the effect. By partnering between research and community, we can begin to work in a greater coalition partnership to advance these outcomes for everyone. Then finally, we have to think about broader targets and begin to actively think about being in the actual room where it happens. That is no longer simply just a catchphrase in a popular musical, but rather is a realistic target. The director of the National Institutes of Health, that position is currently going to become open. And it's important that whoever fills that has a value for equity and an understanding and appreciation for how to achieve that. And so it becomes critical for us in all walks of life to add public comment, to exert influence through our variety of channels, and to affect that position, which is going to have such immense impact on the overall national effort towards health equity. So in the end, health equity, I think, is not simply just the responsibility or impacted by a single position, but rather as a collaborative, actionable effort taking part across ecosystems that has an aggregate overall outcome. And in many ways, it's not a marathon. It is, I think, in many ways, a part of our stewardship as professionals to advance the ball and advance the case for health equity forward for the next generation to then pick it up and further improve upon those efforts in a dynamic system that is always changing. Many of you have probably seen the phrase, be the change you want to see in the world, which is often attributed to Gandhi. And I've honestly, I've watched the Gandhi movie several times with Ben Kingsley. I don't recall the scene where he says this, and looking at readings, I don't know that he actually ever said this. But it doesn't take away that this is a wonderful quote. It's meaningful, and it captures, I think, the spirit behind health equity and its resolution. And that is that all of us can be contributors to a goal such as health equity in our daily lives, and the aggregate of those efforts is going to carry us forward closer to that horizon. So with that, I will go ahead and stop, and I'm happy to answer any questions you might have. Thank you.
Yeah, thank you, Dr. Ruiz. I said this the last workshop we had last week, and I said we've asked our presenters to attain the unattainable and to cover these grand topics in like 20 minutes or so. And so you did, I think, a really great job of really kind of highlighting and really laying a great foundation for our audience and for our work here. I see one question that came in. I'll go ahead, and we're going to take just a quick pause because Dr. Ruiz needs to leave by 1 o'clock. And so if there's questions specifically for Dr. Ruiz, please send those in the Q&A, and happy to share those. And other panelists as well, if you want to chime in and jump in at some point as well, please do so, and happy to have a dialogue as well. It says one came in, Dr. Ruiz says, many DEI efforts have been impactful, yet how can we integrate solutions to the problem, not the problem to the solution? Including, when this individual said not the problem, in parentheses, they have communities, populations, social groups. So how can we integrate the solutions to the problem, not the problems to the solution? Any thoughts about that?
Yeah, that's a wonderful question. I'm not sure I have an answer for it. The phrasing is interesting to me. And the first thing I would say is that, I think when we talk about integrating solutions to the problem, I'm comforted and motivated by the passion that many folks bring to this. And to me, that's not the problem driving things. That's individuals' goodwill, good intentions coming forward, and that the degree to which we can then develop that as skills, develop that to harmonize with others, is bringing the best interests of all forward. And so in many ways, I'm heartened to see that so many people are engaging in this here today, that are thinking about health equity to the point where they're giving up, some time on a random Tuesday to come and be a part of something like this. I'm looking down now, I can now see the participants, there's 237 here. If each of those persons took a few minutes in their day to do something to make somebody else's life better, that's an equity creating effort. If you explain something a little bit better to somebody, if you make an accommodation in your appointment calendar for somebody, if you if you're running research and you say, we shouldn't just have a statistically significant number of underrepresented folks, we should power to that group, and make sure that we can analyze that data. Those are all pieces of that goal. And to me, the aggregate of all those daily efforts across all of us are what's going to drive us closer to that outcome.
Great. Dr. Ruiz, we had a few people ask for your contact information, and so I put that in there. I'm hoping that's okay.
Yeah, of course, anytime. And I know a lot of people will sometimes look at these recordings and a week or even a month later. I'm one of those folks who I believe that you should ask your questions when you have them. You should reach out to those. You should be an ambassador for your passions. So please don't hesitate to reach out to someone like me or others in your community who may be able to help. So please be active in your own destiny.
Yeah, and they want you. We have a few who are going to be inviting you to go speak in their counties, so you might get some more requests.
Well, I'm always happy to talk with folks. Because the more we spread the word, the more our efforts advance. The sooner I get to retire and go home, and the next generation gets to pick up the ball and carry it forward. As I said, I think of all this as a stewardship, where our goal is to put the ball in a better place than we found it.
Yeah, that's excellent. Ileana, other panelists, I'm not seeing any more questions from the attendees, but are there any other questions or comments that came up, reflections from Ileana or the other panelists? Sarah, I say you come back on. Yeah.
I was just going to say there's so much that Dr. Ruiz shared that I agree with. And thank you for putting such a great foundation up for us to follow after you. But again, there's so many different things that you talked about in terms of the definitions that you shared are very much the same definitions that we work with, showing the concentric circles. And I hadn't seen it from the perspective of an institution. So that was a really great way to look at that, the concentric circles of the individual to the structural level, but from an organization's perspective. And then just to name that the role of community-based organizations and the role of community engagement. I know you spoke specifically about the gap sometimes between research and community experience, and how that has a tendency to maybe feel like community isn't as much of an expert, right, in the science perspective, but that actually we know that community is expert in their lived experiences. And so bringing those folks together is really important. So I think again, just want to thank you for your presentation. There's so much richness there that very much agree with and builds on our presentation as well.
Yeah. Well, thank you so much. Yeah, I think, I would also I sometimes will note for my students that our field is not particularly old. We're less than 100 years old as a field. And if you think about that, Homo sapiens have been around for 50,000 years plus. It's not that old a field. But the progress could be improved. The effort could be optimized. And that's why I appreciate, having forums like this to allow us to come together to share ideas, share successes and failures. Because we can learn lessons from both of those that may help guide us forward. I did notice that John Ruiz asked a question. Do you mind if I?
Yeah, no, absolutely. There's a couple more questions there. It's totally good. If you're seeing those, Dr. Ruiz, go for it.
Yeah, I've learned in the Zoom age that I'm not particularly good at monitoring chat and speaking at the same time. So, but John is asking. His question is: in a community participation and collaborations, there's always a dilemma for who is invited to a limited number of chairs. And how do you do that? And this is one of those things where we're gonna have to learn and develop new methodologies to improve our ability to hear all the voices. One successful path that I've seen recently is that quote unquote representatives come forward and participate directly in some degree of conversation. But then those actions are then put back out for public comment. We see things like, the United States Preventive Services Task Force, for example, uses this methodology where a group of experts come together, they discuss a topic, they write up their initial findings or ideas, and then they put them out for a period of public comment to allow for revision or correcting or depth of input to really sort of optimize the final product. So there can be ways that are efficient, I think, to use both focal expertise and representation to manage the crowd size in many ways during a discussion, and the cooks in the kitchen, so to speak, but also get the broader sort of sense of what does the community feel, what do other stakeholders feel about what is being developed. But it's definitely a great question, and one that we can continue to develop on.
And Mario, you have your hand up.
Yeah, Dr. Ruiz, I love that comment, the question, and your reply to it, and also talking about the collaboration that's needed, effective collaboration. I think one of the sayings that you had of being in the room. Another one is if you're not on the table, you may be on the menu. And with collaborations, what we realize, like what I've learned in part of this collaboration efforts, is that you can get invited to the table, and you can also be on the menu. And I think that also it goes from, there is a fear that happens amongst collaborations. And there's a protective thing of, I have my pie of my work that I do, and I don't want to share that pie with anybody else that may be doing different work, doing it more effective. They may be creative on how they're implementing programming. And I think for CBOs, it's a difficult thing, but we have to be open to looking at some creative strategies that there be partners out there. They may be different sizes. They may be targeting a specific population of the community, but they're effective, more effective than some of us. And one of the things as the CEO of a large community center of different programming, I always do look at what do we do that is really effective, but do we have partners that can do it more effective? And if there are partners out there that can do it more effectively than I can, then we want to work with them and we want to collaborate with them. And I think that has to be a key part of the strategy as we go forward, is let's not operate out of fear of not getting and I understand it as a CEO of an agency. You want to make sure you have funding to support your organization and all your team players and your program managers. But we also have to look at opening the door, inviting everyone to the table, and having them participate in the process. That's really the only way we're going to really achieve equity in our community.
Yeah, that's a wonderful comment. I couldn't agree more. That fear is real, and it takes place everywhere from the individual level. I think of my kids and their frenemies, where there is shared interest in something, but also then it becomes competition if there's shared interest, all the way up to professional organizations, corporate entities, and so forth, where folks are trying competitively to fill the space. I think, but the other thing that you said, Mario, that was really interesting is that there are opportunities to build collaborations, and collaborations rely on there being overlap. You have to be able to do that, but then the key becomes how do you harmonize to each other? And the second question is, what's the added value of each group? And identifying that added value can really be the key to ensuring that everybody has a comfort level and a piece that is their own, but is also then adding to the broader effort. And we see that both at the individual level, in dyadic partnerships, all the way up to broader sort of healthcare efforts. So that's a wonderful comment. Thank you so much for making that.
Yeah, thank you, Dr. Ruiz, as well. There's more questions coming in, but we're gonna have to sort of hold off for a minute and let Sarah and Tina chime in. I'm gonna turn this back over to Ileana, and then if there's time, Dr. Ruiz, again before you have to jump off, we'll get to some of those questions. We're tracking your questions, so please put them in there, and we'll get to some of those hopefully before we end today. Thank you again, Dr. Ruiz. Very great foundation, and hopefully we'll get back to you again in a little bit. But if not, just sign off as you need to. Thank you.
I appreciate that. Thank you, everyone. It's wonderful to see you all, and thank you again for coming and participating.
Thank you, Ileana.
I just want to echo the thank you, Dr. Ruiz. It's an honor to have you speak to Orange County.
Oh, thank you so much. And I'm a Southern California guy at heart. You can't see, but I've got my checkered Vans on right now, and it's always been near and dear to me. So thank you so much again for having me. It's been a pleasure. And to the other panelists and folks here, it's wonderful to see you all, and thank you all for your efforts.
Thank you. It's my pleasure now to introduce Change Lab Solutions. Sarah DeGia, CEO of Change Lab Solutions, a longtime mentor. It's so exciting to have you speak with us today too. Sarah is committed to applying her legal expertise and leadership experience to advancing equitable laws and policies that ensure healthy lives for all. Before joining Change Lab Solutions, Sarah worked at the California Pan-Ethnic Health Network, first as Director of Government Affairs and then as Executive Director. Sarah developed and implemented CPEN's policy, community partnership, and research goals. She also expanded the organization through a creation of a Southern California office and increasing the number of permanent staff members in Sacramento. Sarah's accomplishments during her tenure at CPEN include the passage of more than a dozen legislative bills to further health equity, critical administrative policy wins to incorporate health equity into land use and planning regulations, and improving the quality of healthcare for immigrants, patients with limited English proficiency, and community of color. She has authored many publications on the health of communities of color in California, oral health disparities, mental health, and Latino health. Sarah previously also was a health program director at the Latino Issues Forum and a legislative analyst at the Mexican American Legal Defense and Educational Fund. She earned her law degree from the Santa Clara University School of Law and her bachelor's degree in ethnic studies from the University of California at Berkeley. Change Lab Solutions is a national policy organization, and it's a pleasure to have you here, Sarah. Additionally, we have Tina Yuen, who is a senior planner at Change Lab Solutions. Tina primarily works on active transportation and supporting cross-sector collaboration and systems change aimed at fostering healthy, sustainable, and just communities. Prior to joining Change Lab Solutions, she was a planner at Ramey & Associates, working on the nexus of planning and public health. In this capacity, she worked on a range of topics related to community planning, equity, climate change, and sustainability, health indicators and metrics, evaluation, and health in all policies. Tina also worked at the National Association of County and City Health Officials on their healthy community design and environmental health programs. In addition, she served as an environmental public health fellow at the U.S. Environmental Protection Agency, where she focused her research on environmental justice and community engagement in scientific research. It's an honor to have you, both of you, speak to us today on the social determinants of health. I'll also be adding Change Lab's most recent report, how California's community-based organizations fill the gaps for underserved communities and meeting the needs of racially and ethnically diverse communities during the pandemic. So I'll add that to the chat.
Thanks, Ileana. It's a pleasure to be here today to speak with you all. I'm gonna share my screen so that we can get the presentation started. And I just want to note, thank you to Ileana for participating in the report that we put together. It would not have been as wonderful if we did not have her contributions as well. So just want to make sure folks can see my screen.
Yes, we can see it.
Perfect, thank you. All right, well, again, thanks to Ileana and to Mecca for inviting us to share our perspectives today on the role in particular of law and policy to advance social determinants of health. As noted, I'm Sarah DeGia, CEO of Change Lab Solutions, and my colleague Tina is here. You want to say hi, Tina?
Hey everyone, good to see everyone.
And I learned something new about Tina today. So thanks for reading our bios, Ileana. It was nice to learn that about Tina. So in case, for those of you who may not know our work at Change Lab Solutions, we do work across the nation to advance equitable laws and policies that ensure healthy lives for all. And central to achieving this is our focus on demystifying law and policy, because they are powerful tools for change and they have the potential to undo historical harms to affect large numbers of people, and to engage change makers. We're going to talk more about that today. And at Change Lab, as you noted, we have an interdisciplinary team of lawyers, planners, policy analysts, and other professionals who work across sectors to dismantle unjust laws and policies, systems, and practices, and work to replace them with equitable ones. We partner with government institutions, with community-based organizations, and anchor institutions to facilitate equitable policy development that really works to center community and equity in decision-making and change-making. So today, we are going to build on Dr. Ruiz's wonderful presentation. We're going to briefly talk a little bit more about what are the factors that influence health. We'll go through the definitions very quickly because he really laid the foundation for us. And we do have a wonderful visual that kind of talks about the difference between equity and equality that I think will be super helpful for you. We're going to talk a bit about the 5 drivers of inequity as a framework that we use at Change Lab. And then we want to make it concrete for you. And so we have some examples that we want to share from the field. So I'm going to hand it to Tina to talk high level about healthy communities.
Great. Thanks, Sarah, and hello again, everyone. So just to jumpstart this conversation, I first wanted to introduce the elements of a healthy community with this diagram here on the screen. The community, as you know, is where we live, we play, we work, we worship, and attend school. And this diagram depicts these interconnected elements that make up a healthy community that affect our health and well-being beyond just our individual genetics, access to healthcare, or even our behaviors, even though those are also really important elements. This diagram includes various aspects of our physical environments, as well as our social, cultural, and political systems and institutions. And these elements represent the myriad of agreements for what we all need to thrive and be healthy. And we wanted to introduce this as a concept because we want to come back to this throughout our presentation. So next slide, please. But you may be asking yourself, why focus on these aspects of our community in terms of promoting health equity? Why is this important? Well, first of all, studies show that healthcare is really responsible for only about 20% of our health outcomes. About half of our health is determined by 2 determinants: our social and economic systems and our physical environments. And these 2 determinants together shape our behaviors, such as whether we smoke or eat nutritious foods or engage in physical activity that then drive our health outcomes. So next slide. So I was going to go through a couple of or a few definitions that I can go through quickly. But I think it's important to really be clear about what do we mean when we say social determinants of health. The World Health Organization defines the social determinants of health as the conditions in which people are born, grow, live, work, and age. And these circumstances are shaped by the distribution of money, power, and resources at the global, national, and local levels. Next slide. It's also important to be clear on other terms as well, such as health disparities, which are defined as preventable differences in health outcomes. These differences are inequitable and related again to the historic and current unequal distribution of resources. And it's important to note that health disparities exist primarily because social determinants of health are not distributed equitably across and within communities. Next slide, please. Okay, so we've talked about health disparities and inequities, so let's talk about the flip side now. What is health equity and why is it important? And I think it's important to lift up really one important definition from Dr. Paula Braveman. She explains that health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences. And at the core of health equity is this focus on fairness and justice and opportunity. And with that, I will hand it over to Sarah to talk more about equity.
So this is a really good visual about kind of the difference between an equitable approach versus an equal approach, right? So sometimes interventions are like, well, we're just going to create a healthy thing for everybody. And while the intention is good there, right? The intention is represented on the top level, which is let's give everyone a bike so that everybody can engage in physical activity. The reality is that that approach may fit for some people, but it's not going to fit for other people. So the two people in the middle in this visual are going to thrive really well because the bike fits them and it meets their needs. But you can see the person in the front is struggling to reach the pedals. And so she may fall farther behind. And the little boy in the wheelchair may not be able to even get on the bike at all. And so an equitable approach is about meeting people where they're at and really understanding and taking the perspective of that we're designing a project or an intervention in a way that's going to see the potential for efforts that is going to meet people where they're at. So again, we like this visual because it kind of depicts when a well-intentioned effort can actually fall short because it's not thinking about different needs and different perspectives. And all of these definitions are really important because when you are working in a space, whether it's across different sectors, or maybe it's just with different stakeholders, everybody comes with their own assumptions and everybody comes with their own definitions. And so when you want to engage in partnership, it's really important to lay out which definition you're coming from, or what do you mean by, or what is the agreed upon approach that you're going to take. And I will note that I think Dr. Ruiz was saying this in a different way, but it's that everyone has a stake and a role to play when it comes to working towards health equity. And so getting on the same page and having these shared perspectives is really helpful and really important. So I want to just briefly mention another framework that we work on at Change Lab Solutions, and these are called the 5 fundamental drivers of health inequity. And we know that health inequities are really deeply embedded in our systems and institutions. And we often think of health disparities or differences in health outcomes as being based on that individual behavior. But what we're seeking to do with this framework is to really demonstrate and show how it is the structural embeddedness of those inequities that actually trickles down and has such an effect and really causes those disparities or inequities. So before COVID, we knew that disparities were deeply embedded, but we really saw it come to light in ways that we hadn't seen it previously to cope to the COVID-19 pandemic. And so in order for us to really shrink those gaps in health outcomes, we have to have a different perspective and a different approach because we're dealing with very complex issues and complex challenges. And so we developed with support from and a lot of research from across different frameworks and across different institutions, we developed these 5 fundamental drivers because again, they really focus on the systems level approaches that are affecting people's health. And we are also lifting these up because we know that laws and policies play a tremendous role in shaping the systems, the environments, the resources, and the opportunities that are barriers to good health. So this is kind of a framework for thinking about and understanding the role that law and policy both plays in creating and perpetuating inequities, but also how they can be drivers for change as well. And I'm going to name them for you, and I'm just going to define one of them for today, but we name them as structural discrimination and racism, income inequality and poverty, disparities in opportunity, disparities in political power, and governance that limits meaningful participation. So for today, I just want to note that when we talk about so structural discrimination, what we're talking about or how that occurs is when systems, rather than individuals, unjustly deny wealth, opportunity, power, or government representation on the basis of characteristics such as race, gender, sexual orientation, social class, and immigration status. So it's accounting for how multiple dimensions of an identity, as well as interlocking systems of oppression, can shape an individual's experience. Structural racism is one form of discrimination that has been defined as a system in which public policies, institutional practices, cultural representations, and other norms work in various, often reinforcing ways to perpetuate racial group inequality. And 2 examples that we're going to touch on today will help to really underscore the ways in which these systems and drivers affect health. So the last concept I want to talk about very briefly is the role that law plays, or the law as a determinant of health. So law very much feeds into the ways that systems are affected, the way that resources are distributed to individuals, and then how individuals reside, like how they show up or what their health outcomes are. So we believe, our organization really believes that the most powerful risk factors for poor health are actually laws and policies that perpetuate racism, discrimination, segregation throughout our history. And while they have worked to create disparities, they are very powerful tools for change, again, because they affect large numbers of people. They can undo some of the historical harms that we have seen, and they engage change makers into the system. So we're really engaging the people who are affected by these health outcomes into the development of laws and policies. Law and policy may not always feel accessible, but if they're really essential tools. And so part of our work is to help demystify those laws and policies. And as a reminder, policies are not just legislation, right? There are many different types of policies out there. So you may be thinking, this doesn't affect me because I don't make laws, I don't make policies, but many institutions and many individuals do. They come from the range of contracts and agreements, hospital policies, even organizational policies, all the way up to local ordinances and resolutions, right? So they really have the effect of change. I'm gonna, as Tina is now gonna talk a little bit about the role of that history has played, and how not thinking about history or not understanding the role of history in the development of policies can also perpetuate inequities.
Great, thanks, Sarah. So yes, I think it's really important that we understand that there is a legacy of unjust and racist laws and policies in this country that have intentionally and unintentionally led to deep racial inequities along a litany of different measures. Many of these laws and policies have been overturned and made illegal, but their impacts are still felt by us and continues to contribute to growing health inequities. Communities face real and deep challenges like income inequality, growing distrust of government and institutions, a changing climate and impacts on our health, declining life expectancy, and widening health inequities. Understanding and acknowledging this history is essential to redressing structural discrimination and achieving health equity. And it's important to first understand how laws and policies drive structural discrimination, and more specifically, structural racism. And by knowing this, we can use this knowledge to dismantle the structures that reinforce health inequities, including those laws and policies that have contributed to multi-generational harm. And even as many laws and policies have been implicated in creating these harms, I think it's also important to say that laws and policies can also be the tools we use to redress these harms and ensure a just society that embodies our highest ideals and values. Next slide, please. So I wanted to share with you an example of a racist policy, past policy, that still has impacts on us today. This is the often cited example of redlining. Many of you have probably heard of that term before, but this was a practice that legalized racially discriminatory lending and investment practices throughout the US beginning in the 1930s. This government sanctioned system resulted in color-coded graded residential security maps that were adopted by the federal government. And these color-coded maps ranked neighborhoods from least risky to most risky for financial investments based largely on race. Predominantly Black and Brown communities were more likely to be designated as D for hazardous and color-coded red. And this practice resulted in decades of disinvestment and decline in predominantly BIPOC communities. As recent research and reporting has shown us, the effects from redlining are still very much felt today in terms of health inequities from past housing discrimination, increased climate risks of areas that were redlined, declining home ownership rates among BIPOC households, and growing gaps in generational wealth building. And even as redlining was a fully sanctioned, government-sanctioned practice, it took the passage of 2 major federal pieces of legislation to make the practice of redlining illegal and to begin to address its impacts. And those were the Federal Housing Act of 1968 and the Community Reinvestment Act in 1977. Next slide, please. In thinking about structural discrimination, racism, and the legacy of laws and policies and historical harms, it's important to think about the potential equity implications of proposed laws and policies. And some guiding questions are here up on the slide for when we're thinking about these laws and policies. First, we have to ask, who is the individual or community that has been harmed? And this goes back to understanding the history, which is essential to understanding and answering this first question. And the second question is, who stands to benefit from this particular policy and how would they benefit? And lastly, how can we prevent future harm and health inequities? Again, understanding the history is important to avoid making the same mistakes again from our past. But why does asking about equity matter? The short answer to this is if you don't ask these types of questions, then you run the risk of creating or exacerbating inequities through our government and legal systems. And asking these types of questions can provide a helpful starting point for ensuring that our laws and policies do not cause unintended consequences or exacerbate health inequities. And I'll hand it back to Sarah to talk about community engagement.
Thanks, Tina. For the interest of time, I'm not going to run through all of these. I will point you to our Blueprint for Changemakers, which has much more detailed information about some really great practices for engaging community. What I will say is that it's really important to engage community and to really engage them, again, not from the perspective of just giving folks a chance to like respond to or react to something, but bringing them in at the very beginning of the process. And there are ways in which you can assess the readiness of your community and how to engage, like different policies and practices. So you'll have access to these slides. There's a lot of great information there. And I think one really important way to engage folks at the beginning of the process is to really create this shared understanding of what is the problem or the issue, and then looking at and identifying together what are some of the historical place-based and systemic perspectives, questions, issues, or challenges do we want to be looking at, or do we need to be looking at in order to define the problem, in order to get to the solution. And again, acknowledging past harms is a really important way to then create that more just approach to the future. So what I'm going to do is I'm going to dive into two examples. I'm going to share one and Tina will share another. And the first one I want to talk about is the role of exclusionary school discipline and how it is a driver of inequity. And the two drivers that this example touch upon are structural discrimination and disparities in opportunity. So we know that education is a really important way for public health. It is a strong indicator of positive and negative health outcomes. Education attainment is linked to better health outcomes because it leads to better jobs, higher earnings, safer housing, a decreased incarceration, etc. So we look at education as a predictor of lifelong health as well as life expectancy. And school environments themselves are a very important way to build up protective health factors like connectedness, peer connectedness, school connectedness, and positive social environment. And at the same time, as depicted in this timeline, we've seen historical evidence that shows that schools have employed violent policing and discipline practices that are really rooted in discrimination, in racism, and in anti-Blackness. And this goes as far back as the 1800s. And it's no coincidence that in response to the desegregation in the 1960s, that you saw local and state policies and laws that gave teachers, administrators, and law enforcement the authority to identify students as pre-delinquent, which then has given rise to contemporary school to prison pipelines. And today we're seeing the disproportionate effect of those primarily felt on BIPOC students, students with disabilities, and students with intersectional ideas. So the rates in some cases are 6 times as high for some of these communities compared to their white counterparts. And one of those key disruptors is in educational attainment is actually school discipline policies and practices, because they're literally excluding students from learning. And this has become particularly insidious actually during the pandemic, when there have been new models of exclusion that have emerged that are operating simultaneous with some of these traditional kind of suspensions and expulsions that are giving rise to even more disparities in school learning. So I want to shift to some positive ways in which states are addressing or looking at health promoting policies. So they're moving away from these discipline practices into more health promoting practices. And 3 of them include restorative justice, social emotional learning, and trauma-informed education. And what's really brilliant is that in some cases, all 3 of these are overlapping, and sometimes jurisdictions are working on one, but not all of these, but I think it's still very promising to show. The reason why we're talking about state level reform today is because it is the state that's the state that has control over the forms and uses of school discipline, as well as some of the data and collection reporting. So there's not to say that there's not things that could be done at the local level, but this is one of the ways at the state level. And so this is just an example of different areas around the nation who have adopted some of these policies. So you can see that restorative justice practices in green, these are areas that restrict the use of zero tolerance and other kinds of punitive discipline practices, or that are working towards more whole school models. Social and emotional learning, they're more benchmarks rather than legislation at this point, and those are opportunities where students are starting to learn the social and emotional core competencies as they're learning the different subject matter expertise. And then trauma-informed legislation is also kind of starting to emerge in different areas around the nation. So those are just a couple of examples in the school discipline area. And I'm going to hand it now to Tina to talk about a housing example.
Great, thanks, Sarah. So I wanted to turn our attention and talk about housing code enforcement as a driver of inequity. Substandard housing and lack of housing affordability are tightly intertwined inequities in our housing system. And as I discussed earlier in my example of redlining, there's a long history of racist and discriminatory housing policies and practices. And these policies and practices, along with other discriminatory policies and practices, resulted in wide racial inequities and income inequality, poverty, and disparities in opportunity. Combined with the high cost of housing, in many places, families facing these inequities often have limited options for housing and are forced to make some hard trade-offs and are often pushed into substandard housing as a result. So next slide, please. So the connection between housing quality and health are really well understood. Substandard housing are responsible for a wide array of significant health problems, as demonstrated on this slide. As rental housing is more likely to be substandard than owner-occupied housing, tenants are at a higher risk for experiencing these types of health outcomes. And local governments can play a really critical role in improving the health of their residents by implementing programs to improve the quality of the housing stock. And these health outcomes are really associated with substandard housing, are more likely to affect low-income communities and BIPOC communities. In the conventional housing code enforcement model, there are a number of equity pitfalls. It's estimated that around 6 million homes in the US are substandard. About 1 million and 1.3 million of those homes are considered severely inadequate. Renters typically live in older homes and are more likely to report living in housing with severely inadequate plumbing, heating, wiring, and maintenance upkeep. As rental housing is more likely to be substandard, tenants are at a higher than average risk. Traditional code enforcement programs are often reactionary and are complaint driven, meaning that housing inspections are made only when a complaint has been filed, usually by the tenants. And this approach discourages renters from filing complaints and exercising their tenant rights. And tenants may be reluctant or fearful to report complaints about their units because of fear of retaliation, such as eviction or withholding of repairs and maintenance as a result. Next slide, please. So what can be done about this? If we apply an equity lens, what are other approaches that we can take to improve how communities enforce housing codes and improve the conditions of rental housing. An example of this is proactive rental inspections, or PRI. Under a PRI program, rather than waiting for complaints, the locality inspects all rental housing on a periodic basis to ensure that the properties are safe to be inhabited. And this is a systematic approach to inspecting rental housing that is much more effective at improving and protecting tenants' health and safety. Tenants experiencing inequities and marginalization may live in substandard, are more likely to live in substandard housing, but often don't make complaints about it. Again, probably because of fear or difficulty navigating the enforcement code system, which can be confusing. And because PRI is not complaint driven, it can improve the housing conditions without this fear of retaliation. Typically with these programs, landlords have to register, and then when violations are found, steps are taken to rectify the problems and bring the units back up to code. And there's lots of mechanisms to make sure that that happens through enforcement mechanisms. Cities can also design their programs to make sure that the programs they themselves exacerbate existing inequities and don't create other burdens on the renters or overburden landlords with heavy fees and fines. And again, the purpose of a PRI program is not to punish landlords, but to encourage compliance with local housing codes and to promote the health of renters. Next slide, please. So, there's lots of benefits of PRI programs. I could go through it, but, just to be really quick, there's lots of effective sort of like outcomes in terms of reducing the health risks associated with substandard housing. Other benefits found of PRI programs is that both tenants and landlords have a better understanding of their rights and responsibilities, which also can yield some really great outcomes. And PRI can be one of the more effective ways to reduce health inequities because health risks associated with habitability so often affect low-income tenants. And next slide, please. And so we've reached the end of our presentation. I wanted to recap some of the things that we've discussed so far. An effective health equity approach that's anti-racist requires addressing the root causes of poor health. It also requires naming structural discrimination and racism, as well as centering healing and supporting community resilience. Again, promoting systems thinking is really important for understanding how our systems are perpetuating historical racial injustices, and the focus should be on addressing structures and not individuals. And of course, we need to acknowledge and redress past policy harms. And with that, we conclude our presentation. Thank you for giving Sarah and me an opportunity to present on this important topic, and we are happy to answer questions. Thank you.
Thank you, Sarah and Tina. That was a wonderful presentation. I loved your education example. I loved looking at the map of what policies are in place nationwide, and your last slide is on point. So thank you so much. We're going to move on and have more of a panel discussion as we move forward, but for right now, I'm going to make sure that we have enough time to ensure all of our speakers have a chance to speak. And last but not least is Mario Ortega from Abrazar. Mario is the CEO of Abrazar, which means to embrace in Spanish. It's a nonprofit direct service organization providing services to residents in Orange County. Abrazar is dedicated to embracing the diversity of families in our community, educating them on the resources we provide through our community, through their community collaborations and programs, and empowering them to improve the quality of their lives through the health equity programs that they have. The goals of Abrazar are to embrace, educate, and empower children, families, and individuals with the necessary tools to improve health equity by delivering programs that address the social determinants of health. Mario just got recognized by Senator Dave Min during Hispanic Heritage Month. He shared a quote, says, "I'm the youngest of 9 children from immigrant parents from Mexico. They came to Orange County with my 5 sisters to make a better life for our family. Our family has faced numerous obstacles along the way, but we have been able to persevere. I know that our resilience and success are due to our family support and community support. I am honored to be able to address the health inequities that still exist and continue to help improve the social determinants of health for the community through our programs at Abrazar. Abrazar has been a key leader during this pandemic, and I'd love for him to share more about his work and his experiences during this past year and his thoughts. So Mario, please let us know, your perspective on all of this so far, and take it away.
Well, thanks for that introduction. And did I write that? Was I that wordy? That's a lot in there, but I appreciate being part of the panel. And before I jump into Abrazar and our work, I just wanted to say, Sarah and Tina, some of the things that you guys mentioned, really appreciate. I know for my family background, talking about housing and education, it was so impactful to our family. I'm going to try real quick to share a picture. Let's see if I can do that very quickly. Because, let's see, and I promise I'll be short, but can you guys, are you seeing the picture?
Yes.
Okay, so this is my family. There's 6 girls that were all born first of our family, 5 of them born in Mexico, and then 3 boys after that. And speaking of housing, we grew up in Huntington Beach only because my parents could not get a rental apartment for a family of 9, because who would want to rent back then an apartment or a house to an immigrant family in Huntington Beach? What it ended up being as a blessing is that they were forced to actually look at potentially buying a home. And so I had an amazing older sister who was just a trailblazer. And she told my parents and my older sisters too, said, hey, we will work after going to school. And mindful, these are teenagers. After we do our school, we will go to work and we'll help you to pay a mortgage for a home so that we could all have a house. So because of that decision, we ended up growing up in Huntington Beach and having a home. Now, we were one of the only Latino families in Huntington Beach at the time. But what it also gave us access to was education. We had an educational system that was really a great education system that we were growing up with. So we had that as part of our background. So part of what you guys are talking about is, housing, education, and the impact that systems have on families. We are a great case study for that. And I also love sharing my family and the fact that have amazing siblings. So, but real quick, I wanted to acknowledge that and say, it really shows the impact that it has on a family. So with that, I'm going to stop sharing that now, if I can. All right. So going back to Abrazar and now what we've been doing, and it really has driven why I do the work that I do. The reason why I'm passionate about the work that Abrazar does is because I do see with our family of the impact that having access to some of the programs, whether it's educational, even we needed help with food lunch program. We needed help with, we were one of those kids, one of those families got toys from the community, from the church. It might have been a box that said girl 9. And all of us, all the kids were like, I don't care, I'll be a girl 9 if I could get that present. But we had access to these programs that people going up that helped us. And what I love about the work that's happening now with health equity is that before, when you talked about assisting families like ours, it was really looking at families that, okay, well, you're going to create a society that needs support all the time. And you're creating a even dialogue of socialist type of organization or community. But what I love now is that it's really changed the dialogue. When we're talking about health equity, we're really talking about giving people just the access, the opportunity, and addressing that there still are systemic issues that are affecting the health equity of the community. And so I love being a part of being able to do the work that I do. And so one of the things that the pandemic really highlighted is that the work, the validation of the CBOs and all the nonprofits that are out there doing tremendous work. It is really, they exist because there is health inequity. It is because everyone doesn't have equal opportunity. It is, they exist because they have been affected by the systems that are in place and that we're all needed. So I think what we've also seen is that the tremendous work that CBOs do, all the nonprofits, whether it's the Meals on Wheels program, whether it's the food banks like Community Action Partnership and Second Harvest, whether it's the mental health services and the collaboratives that go on that I'm honored to be a part of through MECA that we do with all of our partners, whether it's the transportation to get people to programs and necessities that they need, it really has validated all of our work. And so one of the things that we did early on is that we saw all of our community members that really needed, they didn't know what to do when the pandemic started. You know, they didn't know how to access resources. Majority of our families that use our services, they're monolingual, either Spanish speaking or Vietnamese speaking families, and they did not even know how to navigate where all of their life was affected. Their job, their education, their access to food, even technology, how to do online schooling, childcare. And so really what we were glad to be a part of it is that our team was very creative in being able to jump in and do service delivery and think differently very quickly. So that was one of the greatest things of me looking at my team as being how creative and innovative they were and being able to bring resources and access to services to our community that was really struggling. And along with that, what we early on is we realized that we obviously couldn't do it alone. There are so many aspects to health equity and health inequity that the pandemic just exacerbated. And so looking at partnerships and collaborations, we started cross-collaborating. We've always been an organization that collaborates with the community, but we really had to collaborate with so many new organizations and even change some of the existing collaborations that we had in order to help the community get through it. And we're still doing that work. You know, and some of that work is even that we jumped into is, I'm really proud of the efforts that we've done as a collaborative of even getting the community that has been most impacted by COVID the most to get access to the vaccine. You know, early on, our seniors were reaching out to us. They did not know how to navigate an application to schedule an appointment. How were they going to do that? You know, they download an application on their phone or computer, try to schedule. That was not going to happen. And so one of the things we took that responsibility very seriously. And so what we did is we reached out to the Orange County Healthcare Agency and said, hey, we need to get access to the community to be able to schedule for them. So our team speaks their language. You know, we speak Spanish, Vietnamese. We opened up a call center. We also provided transportation to get to those appointments. We also looked at some of the barriers early on that were looked at of being able to get people to the super pods that were out in the community that did not seem accessible to the community. The reality is that initially they weren't, but they actually listened to us when we gave them the feedback and provided our team to be able to do access to. We have our team would be able to go through a special lane that we created at all the super pods, getting their vaccine on the bus. So picked up from their home, vaccine on the bus, and then back home within a 45-minute period to an hour. That was providing access. That was getting those that were the most vulnerable and that needed and did not have any access before to get vaccinated. And really, we started partnering also with I want to mention a couple of our amazing partners. We have the partners from Mecca, obviously that make up Mecca. You guys can look those all those agencies up. But we also formed new collaborations. You guys might have seen Jennifer from Asian American Senior Citizen Service Center last Friday. She was on the panel. We've done more mobile clinics with them over the last 8 months than I can count. Also, Hope Community Services. Katie Tran is their COO there. We've done so many mobile clinics with them. Orange County Children's Therapeutic Arts Center. Santa Ana Building Health and Communities. El Centro Cultural de Mexico. The Kennedy Commission. Madison Park Neighborhood Association. Oakview Comunidad. All these different new partnerships that I knew of them and I knew some of the great work they did, but we had never worked together directly. And we started working together, and the impact it's had is that we hosted together, we've done over 200 mobile clinics that are vaccinating the community. We provided over 20,000 trips to vaccination clinics. Our vaccination numbers as a collaborative, we're reaching close to 30,000 as a collaborative. That was all about providing access to the community. And so, although Avrasad does a lot of services, we do a lot of different programming, everything from a financial coaching program to our basic need food program. But really is at the end of the day, as we look at what are the needs of the community, and especially during the pandemic, we saw what did they need from us. And the biggest thing they need is that they needed access. They needed access to services. And I think that really is our challenge going forward is the reason why all the CBOs that we exist are because of that the community needs our services still. And they need access to the services. And so now we need to see all these collaborations in our efforts, how do we move forward and do effective collaborations that can continue to impact the community. And I know we need to wrap up, so I'm going to go ahead and move it back over to the panel. But I'm here for any questions.
Thank you, Mario. And we have time for some closing comments from Sarah, Tina, Miguel. Please let us know, how do we move forward? You know, there's been a lot of policies lately at a national level, at a local level to help address health disparities. Any insights that you can have as we sort of hopefully here in Orange County move forward to address these health disparities and recover from this pandemic?
I saw Sarah responding to an answer, so I don't know if Sarah, if you want to sort of say something to that
Yeah.
question or not. Yeah, okay.
I started typing and then I was like, oh, this is the perfect response to Michael's comment. And I just want to say, like, thanks to everyone for your questions and for noticing, words that we're missing, or like, we want to be as inclusive as possible. But there's two comments I want to make. One is I just want to underscore what Mario was speaking about, which is that we saw from the pandemic the way that community-based organizations like stepped up and pivoted and just operated so differently than normal day-to-day. I mean, people do this on a normal day-to-day basis, right? You're totally doing amazing work, but it shed light on it. COVID shed light on the way that people could be flexible, and just the creativity and the innovation and the leadership that community experienced during COVID. Like, COVID gave people the opportunity. I mean, it's like an unfortunate way to understand or to see the benefits, but it really did. And I think part of the report that we did, where we talked about organizations like Mecca and your partners, is to say we do need to have a more participatory type of democracy. We need to do policymaking, especially at the local level, in a way that is far different than what we've done before. Community-based organizations are the local infrastructure, and so they need to be at the table in terms of planning and thinking about policy development, because they have so much knowledge that we're not in thinking about when we're rolling out programs and services. And so we do have a series of recommendations for that, which I think are really speak to what Mario is talking about and others have experienced. And then the other like really amazing thing I would say is that local communities are laboratories for change, right? That's Change Lab. Part of our name comes out of the idea that it's where local solutions are where it's at. And so I really want to encourage folks to think outside of the box, to talk to policymakers, to build relationships with folks, to show up at meetings and to share examples, because that's really where that interaction and that participatory engagement really works. There are some examples in our report. Mario spoke to some, Ileana I know has others, but I just wanted to name that to hopefully answers the question, like there's no one formula, there's no right response. Part of it is like testing, trial and error a little bit.
Awesome. Thank you, Sarah. I love local communities are laboratories for change. I'm going to quote you on that from now on. So
I did not say that. That was, I think, actually in a lawsuit somewhere. So don't credit me.
Thanks. And Tina, do you have any last thoughts?
Yeah, thanks again for having us join the panel. This is a really amazing conversation to be a part of. I'm so heartened by the enthusiasm around sort of tackling these really hard, complicated issues. Structural discrimination and racism is not a very simple thing. It's a hard thing. But I do think that we are at an inflection moment in society. I think the pandemic has really brought about a very sharp focus on social and health and equities in our across the country, and has really shined a light on this. And I think we're at a moment now that we can really capitalize, if you want to sort of turn chaos into opportunity, and sort of building momentum towards really creating transformative change. And I think that, the federal government, state government, I think they're coming around to this. And I think the federal government, with the new infrastructure bill, with ARPA, and a lot of infrastructure funding, community infrastructure, not just physical infrastructure, is really sort of emphasizing the need to do things differently. And I do think that we're at an inflection point, and just, how can we take and harness this opportunity to make that transformative change? And I just want to say thank you again for all that you do. And Mario, I think the work you're doing is fantastic. So thank you.
Great. Thank you all. And Miguel, do you have any last thoughts?
You know what? No, I don't. I think everyone said it well. I'll just say that there was a lot of comments in the Q&A chat that how wonderful everyone really responded to your presentations and all the information. So really want to thank you again. Fill out the survey. It's in the chat there. So locate it. We'll also send it to you out again when we send out the presentations. You will all get a copy of the presentations, the recording. Check out Change Lab Solutions. Their website's also in the chat as well. And then I think this just reminds me that maybe it's not the individuals in our communities who are not well, but the systems. Systems are not well. And so, we hear that a lot, and this sort of reminded me of I think that, and really illustrated that really well. So appreciate everyone being here, and thanks for all the panelists. Really great stuff. Thank you.
Yes. Mario, one last thought?
Sure. Last thought is I'll say Tina had it right on. And it wasn't quite there of the phrase, but it was right there. And it's really about inflection point, equity moment, turning it to an equity movement. And that's what it's about right now. And there's never been more opportunity to have this change happen. And that is going to take a long-term impact on the community. So I'll leave it at that. But I thought that was perfect, Tina.
Thank you all for being here today. And we have our next session on December 7th. Please join us. We have some great speakers lined up for that one as well. And Sarah, it's such a pleasure. And we actually will look forward to working with you on a Community Voices report here in Orange County. And we welcome everyone to have a voice in that as we move forward. So more to come on that. Thank
And
you all.
Ileana,
Thanks,
one thing,
everyone.
Dr. Tamara Bryan Davis was just elected president-elect of the American Psychological Association, and she'll be our speaker on the 7th, one of our speakers. So come listen to her. Come listen to her. Yeah.
Yes, we have excellent speakers. Thank you all and have a good afternoon.
Bye. Thanks.